roughly about 4 centimeters above. So routinely I practice the 5-minute trucker. The side channel is open up. Then just elevate it and make it fast by screwing fashion. So whenever this rectus is crossed, then I withdraw the trucker, then I make it fast, and then I sure it go inside the peritoneal cavity. Then I insufflate the abdomen with carbon dioxide gas, 3 liters per minute flow. The pressure in the hernia initially about the 15, then change it to the 12. So after introduce the supraumbilical port, then the position of the patient is head down. Head down. Okay. This head down is mandatory. Whenever do the head down position, tender position, so it can be spontaneous reduction of the intestine from the pelvic cavity to go up. And if you need to some manipulation with the bowel gasm process. So I start. First, I introduce the 5-minute telescope. Five-minute telescope. I inspect the abdominal cavity. Then I go subsequently the other. Look. So look. So the ultrasound findings is correctly say the facet lies at the deep ring. So you can confirm with visualize by the telescope. So look, this tender position, how all the small intestine go towards the head side spontaneously. No need of manipulation of the fat. If you do surgery, less manipulation, the outcome of the postoperative period is more better. So position of the patient can helps you doing the surgery more comfortably. Now I can do the other port. There is no hernia on the left side. Look, on the left side, there is no hernia, intact. So in that case, you can make the port on the left side port a little bit down. If you do the bilateral hernia, in that case, both the lateral port is the line of the umbilicus. But whenever doing a one-sided hernia, in that case, the lateral port on the left side is a little bit down. So it can more ergonomic to do the surgery. But I do at the level of the umbilicus because the placement of the monitor, look, monitor, the monitor on the straight on the left side. For that reasons, I make the ports on the equal level of the umbilicus. If I position of the monitor on the towards the left, right, in that case, the port has on a little bit down. But here I put the monitor in the midline, straight for that reasons, I do the lateral port at the level of the umbilic. So these are two into the 5. So look, this vision is little bit not, it is not clear to some extent because it is a Chinese telescope. So for laparoscopic surgery, if you use the separate telescopes, separate instruments for the hernia, it can prevent stent. it can prevent infection. So this 5 mm is used for only for inspection. But now I change the supraumbilical port into 10. So in that case, I can use 10 mm telescopes. So after introduce the 10 mm telescope, you can easily compare what the vision changes in the 10 mm 4K camera telescope system. So the image quality is so different with your quality of mesh. So look, this is the umbilical scar. This is the umbilical scar. So look, maybe sir. So look, the vision. Look the vision, how clear the vision is. Next, the position of
লাইভ
the
অডিয়েন্স দেশের মধ্যে দেখো
patient, hold it. The position of the patient needs to change to some extent. What the change is? The change is we'll work the hernia on the right side. For that reason, the table is tilted on the left. Hey, table tilt. Bambi albo katter. So good. Okay. Now I need to create the pneumo dissection of the peritoneal pre-peritoneal space. For that reason, I make a hole over there. But before that, I think, can I go the orchiectomy fast or can I go orchiectomy last? So I think, look, this is very important, interesting thing is, so the testis is not descend down. So what this structure is, look there, what this structure is. It is not the spermatic cord. So what it is? This is called gubernaculum test. This is called gubernaculum test. So this gubernaculum test is not possible to shorten, so the testis is not descend down. So this is the gubernaculum test. It is not the spermatic cord. There is spermatic cord here. So whenever the orchiectomy is done after mobilization, so this gubernacular test is divided and then pulled down. But whenever go for the varicocele ligation of testicular vein, nowadays all the vein are ligated. So this can survive by this supply through the gubernaculum testis and the supply of the heart. These two supplies survive the testis. For that reason, nowadays, in case of varicocele, they ligated all the structures over there. So this gubernaculum, we don't able to see in a normal individual. So these undifferentiated testis can represent this is gubernaculum. I don't go division of the gubernaculum now. I go later on. Now, I guess, come on. So I don't able to lift up the peritoneal surface. Why? Because this is stress. So where I make the hole? Before making the incision, there is my self technology to insufflate the abdominal cavity. Look, this is a spiritic needle. This spiritic needle, this is used for aspiration of the gallbladder. I go through the 5 mm lateral port, then I fires the just peritoneum. Okay, hold it. Look, external view. Going in. So look, there is a insufflation. but it is more insufflate if you deflate the abdominal gas from other trocar. Go, deflate. In that case, it's more space created there, and it is automatically that dissection done in the pretrocar space to some extent. It is my innovation. I usually practice in that way. Then we go and elevate the margin and make an incision over there. Already the peritoneum is separated to some extent from the fascia muscles. Look, go inside. I usually use less amount of diathermy because this diathermy causing subsequently there is a pain. So more burn, more inflammatory process there. So there is chance of more post-body pain. So look, this incision not go beyond this. This is the medial. This is the medial umbilical ligament. So in the midline, median, this is the median umbilical ligament. This is the medial obliter umbilical artery represented, and inferior epigastриc artery over there. So this folds the lateral one. So these three considerations always take during making the incision in the peritoneal cavity. Am I audible?
Yes, sir.
Yes, sir.
So before that, whenever you can go, hold it, whenever you go for the diagnosis of antecedent testis, in that cases, you first see lift up. Okay. You first see two things. What things are? You first see the vas present or not. The first thing is see the testicular vessels. Second thing, you see the vas. If these testicular vessels up to this deep ring, that indicates the patient having antecedent testis in the inguinal channel, which becomes subsequently torsion and atrophy there, or which is called a vanishing testis. So the vanishing testis or not is diagnosed by seeing this testicular artery. This testicular artery go up to the deep ring or not. If go there, definitely the testis go down. So this is the one parameter to diagnose during laparoscopy. The testis is descent or not. That means atrophy or not, vanishing testis or not, or if it is it is not developed. In that cases, the testis is developed or not. It can be detected only by doing the selective angiogram. If you do the testicular artery angiogram, if a length of testicular artery is seen there, that indicates the patient having the testis is developed there. And if you need to some extent visualization more, not that way, in that case you can go to some extent down. So if you go down, so there is more space, easily see inside the lumen of the preperitoneal space. Look. And that dissection, how far you go? You go up to the pelvic floor, that means 2 centimeters at least below the symphysis pubis. Look, there is this is called lighthouse. This lighthouse, okay? If you dissect more and more, then you can see, okay. And this is the lateral wall. You go subsequent dissections. So medial dissections to some extent complete there only needs to extend lateral go. Okay. You look, you must cross the midline. You go up and up as far as possible. If you go above as much as possible, because you can, if you more dissections in the upwards, the upward placement of the mesh is very comfortable. Otherwise, it's very difficult to manipulate and place the mesh over there. So look, up to that level, I don't use any source of diathermy. So this is depends upon your attitude and decisions. Again, extend operator. So this lateral dissection, you must need to assess. How we assess? We assess, we can palpate from exterior, identify the entracerebral spine, and single finger press. Okay. So I can press again. Okay, single press. So this area is dissection entracerebral spine. So this is the lateral boundary of the dissection level. Okay. Next, go there. So there is loose area tissue there. So this is transverse abdominal muscle sling, which can crossing the deep ring. There is spermatic vessels over there in the deep ring level. It crosses there. So that I easily divide with the ligature. So less thermal effect there and more hemostasis there. I easily conventional unipolar diathermy, very minimal I practice. So our lateral dissection operator pass over there. So operator hernia will undergo in. So in that area, operator hernia will be present. So this is the bone. Look, this is the symphysis pubis, and this bone, symphysis pubic bone is crossing there. Finish. Go on that side. Yes. Next, I can decide to dissect the submersions over there. So this operation you can do with confidence because there is no scope to preserve the testicular vessels vast difference. So in that case, it is better you can dissect the cord, not the cord here, only the hernial sac here. And this hernial sac containing the gubernaculum test. Go in. So inferior biggest artery over there. Go in, keep it down. So this is inferior biggest artery over there. So it is medial to the deep ring. So the hernia is indirect inguinal hernia. If the hernia protrudes through this area medially, direct inguinal. But here, indirect one. Good. So look, hernial sac along the vas, not vas, along the gubernaculum test over there. So I can safely divide over there. So that can, so the gubernaculum has the fleshy fibers there. So sac is open here. The gubernaculum is come in view. In normal hernia, we can manipulate the sac from lateral to medial. Lateral to medial. So easily can hernial sac is separated. Go in with the alignment. Weird. No. Okay. So this is the gubernaculum testis. Over there, if you use this ligature, you can more confidently divide it and burn. No, wait. Again burn. Then in the middle, burn, divide partially, not whole. So it can secure hemostasis. So thick the gubernaculum is, look, so thick. So according our anatomical knowledge, before seeing this picture, our conception is the gubernaculum is very thin. No, if it remain viable long, in that case it become more tough structure is. So I divide the gubernaculum over here. Now the testis is delivered through this hernial neck. The sac is open there. So the testis is inverted inside the hernial, that means prepotent space. So there is no testis seen inside the peritoneal cavity. Go over there through this hernial neck. Okay. Now I divide here. This part is, look, go in. Good. Okay. This part is very important one. What important is the test is delivered through this defect come out. Then I see. So normally, whenever testis is there, so there is a testicular vessels. From down there is a vas difference, but both the things go up here. There is no vas, so the vases come this way, and there is no testicular vessel there. So now the triangle of so this triangle of dome is open. This triangle of pain. So look there. What thing you look? Look there. You don't touch this fascia. If you touch the fascia in front of the muscle, so there is chance of injury to the nerve. Or if you bear the fascia, subsequently, whenever place the mesh, it causing there is inflammations and the nerve become irritated, the patient feels pain. For that reasons, always you try to keep the fascia intact over this area. And another important thing is don't make the fixation, don't fix the mesh above the iliopubic tract. That means this area is bone, there is a iliac bone, so this is the inguinal ligament over there. So below this, never fix the mesh. So you fix the mesh in upwards, medially or laterally. So this is the deep ring. So the testes don't go down and the hernial content not go too much. For that reason, this area is not too much wide. So look, this is the inner view of opening of deep ring. So look, there is another opening there. This is the gubernaculum testis, which to some extent peritoneal sac. So that may presented as a subsequently some hydrocele. If there is a more collection there. Or if there is more hematoma, that may go down and subsequently the posterior period depends presented as a seroma or the hematoma in the remaining section. So look, everything, the dissection on all spectrum is finished. Only remains to some extent in the upper part. And this dissection is very important one. You must dissect as much as possible, because whenever you place the mesh over there, if you don't dissect, the mesh become go up and there is chance of recurrence. So the upward dissection is very important to prevent the infection, recurrence of hernia. So am I audible and clearly visualized?
Yes, sir.
Okay. Now the one thing is more remains there. What thing is? This thing is the upper, this upper flap, you need to some extent more dissection. If you dissect more, so the upward, the mesh can easily place over there. But one thing always consider during manipulation, you don't manipulate the inferior vagus artery, don't tear the artery over there. So this dissection do carefully. Okay. Now all the spectrum of, that means surroundings of hernial preperitoneal space, I dissected safely, meticulously, without applying the diathermy in the dissection, only applying the diathermy for division of the gubernaculum testis and hernial sac dissections. Now, this is the testicular vessels along with vas, everything is there. So I want to apply a extracorporeal Rudolph's knot over there. So it can close the hernial sac, it can hemosynthesize the testis bleeding, it can also hemosynthesize the vast difference blood supply, cut up. So I apply a Rudolph's knot with the extracorporeal knot over there, hold it. The appendix, just like doing the appendicectomy, in that way, same thing is done over here. Hold it. So cross the testis, cross the testis, throw this loop, and lift it up, hold it. Again, there is a very important thing is down, just here. Where you apply this Rudolph's, that means look, I don't apply there. I apply over there, beyond the hernial defect. I apply the Rudolph's knot over there, but I don't divide the sac now, because if I divide here, suppose, then there is no chance to revise the suture. So after finishing, I want to close it. If there is any shortage section, in that case, I can divide and switch over the tie over there. So in that case, loose peritoneum I find there. For that reason, I don't divide it now. I divide after applying the mesh and closing the peritoneum, then I divide. Am I clear? Everybody happy?
Yes, sir.
Now, I want to go 5 minutes. I take to go. So, prevention of mass infection. What are the measures you've taken? So, one of the measures is, now I change this external. Time, external view. Camera देखा है, flip करी इधर, इधर मत करी, इधर करो, इधर. Now I change this. देखो, now I change this 10mm port. I change. I fresh 10mm port I introduce over there in the same defect. Okay, change. Now, come here. And before taking the mesh, I must change the gloves. So these are the prevention of infection after doing any open or laparoscopic surgery. Hold and wear the gloves. Cut off. Fresh normal saline taken. Divide the hand and wash the powder. Glass photo dao. Pane dalo hate. Okay. Wash the gloves. So there is no talcum remains in the gloves. So this is a 3D mesh. This is a 3D mesh. So it's a preformed shape, convexity forwards. And I poured some gentamicin injection prophylactically in open or laparoscopic surgery. I usually apply over there. I commonly use it. So then how you introduce the mesh inside the abdominal cavity. So this is folding like that way. Hold it. So this medial side, M marking is there. That dictates this is the medial end. So right-sided mesh used for the right, left-sided mesh right, left. So right-sided mesh medial is directed toward the left. So hold it with the forceps. Look, remove the trocar valve. Then you introduce safely without touching the skin. And at the same time, needle, so I also introduce a 10 vital switches. Throw this trocar without so on the last webinar, we can miss the 10 millimeter needle, the 10 becquerel switcher we miss and takes time. From that experience, I don't push downwards. I push the switches upwards. So if I push the upwards to some extent, so less chance of less chance of missing the thread and needle after introduce the telescopes. The maiden to go to go. Yes, sir. So this is a fresh trocar. Wait, fine. Made it so. Reduce it. Reduce it. So 10 becquerel needle, it is জানো straight করে দেই। Look out. Yes, well. Hello. Wait. So I can check the switcher, place it over there. I take a little bit longer switcher so I can give many bites in the fixation and the peritoneal closure. So look, blindly whenever I introduce, it can easily enter inside the opening in the peritoneal opening. So hold it and you lift this lower flap, easily go inside. Go inside. After inside placement, if you place the lateral end, then the middle can easily fitting there. So this is 3D large size mesh. There is three sides of mesh: small, medium, and large. Always take the large, not the extra large. If the body is European, longer body, in that case, you use the extra large size of mesh. So look, this lower flap is not placed properly. For that reason, I pull up the upper end, then I press with the left side, left hand, so it can easily fitting over there. Look. So automatically the mesh is placed. Look. Can you appreciate it? So nicely placed over there. So our aim to cover the defect, medial side and lateral side. Now the time is mesh fixation. Why do you fix the mesh? This type of 3D mesh, if you don't fixation, no problem. Easily it can place over there. But I always fix it. One for the practice of the stitches. Another one is more assurance, more sure the mesh is not subsequently displayed. Next, the fixation of the mesh. Rest of the world except Bangladesh, all the peoples are close with the proline suture. I never use it, particularly in the TAPP. I always use the vehicle mesh. It is more comfortable for me. And it is valueless after 1 week or 2 weeks. It displays here and there because it is a closed space. And there is no infection for the vehicle switches. According to my experience, I cannot discover any sort of infection after using with the vehicle. Only one infection is happened very early periods, because at that time the technology is not all things are knowing by me. At that time I don't wash the hand with the normal saline, and I don't change the choker, so don't use the clindamycin. So in that case, only one case is in the very early periods. Hold it. So this is the pubic bone over there. So I need to bite in the Cooper's ligament. This is the main challenging part of surgery. Every rest of the things is very simple, but this is the main challenging part of the surgery. I feel, may not be feeling the other individuals, but my feeling is the main challenging part of this fixation of the Cooper's ligament. Victor now? Victor go? Double up. Okay. Okay. Good, keep good. Go. Okay. So whenever you take the bites, this thing is very important thing is, but don't pull without placing the needle holder at the side of pious. Otherwise, the suture along with the Cooper's ligament may tear out. And one, After that, you open the jaw. The first one, it remains there. Then you go inside and hold the smaller end. Then the important thing is you cross with this forceps. Cross with this forceps. Loosely fit, not the tight, not tight. Loosely fit always. If you're too tight, so there is chance of tearing of the fiber of the Cooper's ligament, and this can become lost. For that is just you make a tie with a just as simple loose. Okay, look. So my main critical part overcome. So this is the main enjoyable part of the surgery in TAPP. Next, fixation. I usually fix in a 3 place, but most of the surgeons they fix in 2, one medial, one lateral. But I usually practice in the 3 places. Hold it, hold it, hold it. But these 30-degree telescopes rotate the lens so you can see how comfortably. Exterior. Look, during taking the bite in the roof, the Vitidona. Look, during taking the bite in the roof, you press it there, so it helps to take the bite comfortably to the parietal wall. But during this bite taken, always careful. You may injure the inferior pituitary artery, which is placed very close to it. You must take the bite away from the inferior pituitary artery. If you pierce the inferior pituitary artery, you do surgery, but you can face some troubles. So 1, open the jaw, then 2. If you're interested, you can go to 3. If you make the 3, it is better. No need of further stitches there, because this 3 is not capable to dislodge subsequently. Okay. If you expert enough, you can take another throw over there and reverse throw, and you can take it there and fix it there. Okay. So this 2 fixation is complete. Now, I fix the mesh in lateral point. So lateral point is over there. So change the telescopes and go there. Look. So nicely placed. So again, whenever you take the bite, so look. So this is the lateral side. Make a compression over there and take the bite inside the needle. You see single skin. Okay, good. So this so look, if you without pressing there, the mesh will draw. For that, you always place the forceps or the needle over there, then pull the threads. It can help to prevent deflection of the mesh. Okay. Again, 1, open the jaw. 2, I can give 3. Hold it and make the pull and fitting the thigh. Fit the knot. direct hernia, after dissection the making the there is pseudosac there. In that case, you must do the pseudosac ligations in the parietal wall muscles. So then, no. Then it is post-operative less disturbance because that pseudosac hold it, creating a false bulging there. 20 big 20 big 20 big. So look, I can make some suction. So to some extent of exudate there. Look. So this 20 becquerel only we need to closing the peritoneum. So 8 centimeter or 10 centimeter is sufficient. But I take to some extent more because these sutures are used for intradermal stitch given the port for that reason. So how we introduce the sutures from exterior? One method is towards the trocar. Another method is hold 1 to 3 centimeter distal to the needle. Then you make this previous trocar. Look, in. So the needle and suture also passes over there. So these are the two techniques to close the, to introduce the suture with needle in the peritoneal cavity. Now, our main function over sakaron, sak. So this is the no suction needed. No suction needed. Okay. Now, how to close the peritoneum? So hold the needle. At that time, some manipulation needed. The manipulation is the gas in suffocation pressure, abdominal gas pressure is released. So this go down. Previously, it present about 14 to 15. Now it is 8 to 10. So if you make the pressure down, so abdominal cavity become relaxed, the peritoneum become loose, you can take the bite more comfortably. So this is the tips for closing of the peritoneum. If you use the V-lock sutures, so this initial tie is not required. So crossing the needle through this loop, then you can proceed forwards. So some blurring of visions, I want to warm the telescopes, then I proceed. Anybody, any question up to that level? Any comment?
আসসালামু আলাইকুম স্যার।
Aslam?
স্যার নুরিয়া বলতেছি। স্যার
Okay.
নুরিয়া স্যার,
Amy?
হ্যাঁ স্যার। স্যার ওই
বলো।
যদি স্যার আমরা ওই ফিক্স না করি, if you don't fix it with any
Yes.
protein or tacker, if you don't fix it, will it get migrated to lower portion of the sac or the yes sir?
Easily possible if you use a soft, low, that means the low weight mesh. If you use the medium weight, it is really not possible. But in case of lightweight mesh, whenever used, in that it is
Yes,
very
sir.
soft, there is chance of migration there. And if the hernial gap is wide,
Yes
only
sir.
that case, and if the patient is direct hernia, big direct hernia, there is every possibility of. In case of big direct hernia, always must fix it. I don't use any tracker because tracker is a
Yes.
very bad thing.
Yes
If you
sir.
apply a tracker over the bone,
Yes sir.
if the patient develops osteoitis pubis,
Yes yes.
our orthopedic professor Cyrus Sakiba, he did surgery in India 8 to 10 years back. After that, he developed osteoitis pubis, and
Yes,
there's a
sir.
pain over there. 1.5 years required to solve this problem. He's unable to walk. So the patient who develops this osteoitis pubis, you don't know. For that is another thing is, if the patient having a mesh infection, So in
Mm.
that case, you remove the mesh, you must remove all the trachea. So before
Mm.
removing the mesh, you must do a plain X-ray abdomen. You count the trachea.
Second number, yes.
Otherwise, there is chance of trachea remains there. There is discharging sinus. And sometimes this trachea made it very difficult to identify
Yes,
during
sir.
the mesh infection. If
Yes,
you
sir.
apply the suture, you can fix it there. So suture having a color there within the access cavity, you can easily look that there suture is there. You cut it and remove it out. And if you apply the Vicryl, so in a long run, it becomes absorbed there.
Yes, sir.
For that reason, I don't use any rolling suture. Don't use the trachea. I always use the Vicryl. So there is no harm up to my experience. I did this laparoscopic hernia surgery about 10 years more. This is my experience in our country, 10 years. I use this laparoscopic TAPP, TAPP, etc. So according to my experience, I used these Vicryl sutures. They're very comfortable to handle the suture and do the stitches very comfortable.
So is this a normal Vicryl or the B-lock, sir?
No, normal Vicryl.
Vicryl.
Normal Vicryl.
Okay, sir. Thank you, sir.
Welcome. I 3-4 bites already taken. I don't give any sorts of interlock, but after 2 to 3, 4 bites, it is better to do the interlock stitch. So that can remain the suture stable. So, but if you need to subsequent manipulation, loosening the stitches, in that will be difficult. So there is no scope to subsequent release the stitches over there. For that reason, I can interlock there. So this can, if I remain there, it does not lose the stitches proximal part. So look at how this upper lip fold. If you expert enough, in that case, you can take the 2 bites in the same time. But if you're not expert enough in earlier surgeon, in that case, you take in that, hold it. So hold it and take the suture out. Then you can go the lower flap. If you expert enough, in that cases, you can take the both bite in a same time, needle pass in the upper flap. So look. So this thread can disturb to some extent long threads and take also more time to manipulate the needle and sutures. So short suture can help to comfortably do it and save the time, but you cannot save the money. So these are the important materials. For that reason, if you use less important materials, less consume, less money expense to the country to save the dollar. So this is the dollar exchange imported items of the market. Nowadays, our local company, they can import some sutures and fact here. It also good enough, but not good like that way. Except I will use in my medical college all the patients of the local sutures of Vital in Incepta company, probably this. The name is Polisop or Polisop. So use it little bit soft, but can do the work. There is no infection I cannot see in my hospital in last 6 months after using this local Vital suture. We
Sir,
only,
I have a,
yes.
sir, how to prevent the buttonholing of the peritoneal flap?
Yes, this buttonholing prevention from very beginning always we thought you handle the peritoneum gently. Whenever you dissection done, this peritoneum gently handle. I can describe later on how I close it. Finish that knot. Good. Look, I cross it. 3, 4. Okay. Now, you go. Hold the needle, pull it out. No. So look, there is to some extent disturbing there. Don't cross it. So there is some disturb. What disturb, I don't know. Usually, this can easily go. Okay. So 3 can easily migrate, but whenever apply the 4, easily don't migrate. Look. So easily glide the knot. Look, if any confusion with the loose there, you can take another bite. So don't worry, I can take it. So no scope to lose. If you make it loose, there is chance of entry the abdominal contour over there. So if any confusion, no confusion remains. In that cases, now the ending time is very crucial because this time you become tired. So in that cases, this work is not so fine. So I can close it again in a traditional manner. Hold it. Good. Big enough. In that cases, you must need to divide this loop. Look, going. No. If there is a big loop, you must divide it. Otherwise, there is an entrapment of the momentum over there. But it's smaller one, for that I don't go. Divide it. Finish. Now, guess on. Yeah, guess baro. Guess baro. I want to divide it. Hold it. Hold it though. So there is no scope to release the thigh, no needed. For that reason, I want to divide it here now. So that division again, you must take to some extent of stump. Otherwise, this loop becomes lost. And again, there is the opening of the hernial sac there. Hernial neck we can open up. There is a recurrence content enters inside the cavity. And the patient having to some extent of pain there, which is not presented externally due to the mass, but their defect is due to this defect causing the content enters in front of behind the mesh, in front of the peritoneum. And another important thing is always you must do histopathology of the testis always. You don't know is there any change of malignancy over there. So you must need to documentation. For that is you must send the specimen for histopathological examinations. So the testicular artery the direct branch of aorta. So it is a high pressure vessel. So always look carefully that burn it more towards this area, then you divide. Yeah. There you go. Now, I need to check the stump of the testicular vessel. Yeah. Is that what I saw? Good. So look, there is no oozing there. No oozing there. So I don't take any bite over there. If I having any confusion of collection there, bleeding, then I can make another continuous stitch over there. If I think that there is chance of slippage of the neck of the hernia sac, then I can take a bite over there. I don't start the stampede. Now, how we delivered this? How we delivered this testis? The testis is not capable to expel out through this Bangalore. So through this retrieval. So look carefully. So look, there is some oozing there. Am I clear? So you must carefully look. Like I said again. So this is very important to observe to some periods of time after closing the stump, because the stump is got many structures there, thick stump there. For that reason, there is the compression is not sufficient in the testicular artery. So look. So do surgery in the posterior period. If there is bleeding, you don't recognize it. So there is a morbidity develop. So for that reason, the stump you check carefully. Always you check, recheck. Hold it. So never use the sucker in the cartridge. If you use the sucker in the cartridge, you manipulate the clot, and there is chance of dislodgement of the clot and oozing there. If any confusion, you can relax the gas, wait few minutes, again inflate it. That abdominal pressure causing more pressure over the vessels, so small vessels cannot be able to open up and bleed. For that reason, you can use few minutes and check, deflate the abdomen, hold it, and again check. Hold it. All right, yes. I remove the needle. I don't interested to take more time of particularly the needle thread inside the abdominal cavity. When the job is over, you can remove it out. Now, how we deliver the chassis? No. It back door. Going. So there is a custom made retrieval bag is manufactured here. So the camera cover, sterile camera cover is divided. One is covered with the threads. So this bag is manufactured. I can place it inside the abdominal cavity with hold. So hold the bag distal to the threads, not proximal to the threads. If you use proximal to the threads, there is chance of tear of the bag. So this important thing is hold it and make a twist. So that twist helps to decrease the caliber of the bag. You can easily comfortably do inside. So hold the valve, okay. So go inside. Now wait, normally go. I wait few minutes for observation. is there any bleeding from the stump or not? So this observation is better. So deflate the abdomen, wait few minutes, then observe again, is there any oozing or not? And another important thing is after delivery the testes, we can close the port 10 millimeter with direct vision by suture passer, transversal closure. But before that, before we draw the camera, I aspirate the pre-peritoneal gas with a peritoneal needle, so it can easily placing the mesh. There is no air there, less chance of displacement. And usually, if you don't go with aspiration, the pre-peritoneal gas, no harm because the gas is subsequently absorbed. And that aspiration you can do carefully. If you do the aspirations with parts in the peritoneum, at that time again you may injure the inferior epiphyseal vessel. So all the time, these anatomical landmarks over there, this inferior epiphyseal artery is the main culprit for nonsense creating during surgery. For that reason, this inferior epiphyseal artery always look and do carefully. Now, so look, I can introduce the retrieval bag over there. So last night, the retrieval bag, I placed for splint delivery at the mouth. I placed the passing sutures with the 10 FR drain tubes. But here, I don't apply any sorts of passing suture with the ear because it is a small specimen. No need to open up whole specimen over there. Then this is not possible to deliver through this 10 millimeter port. I don't agree to enlarge the port always until and unless it is a cancer. So it is not a cancer disease. So for that reason, I can split up the testes. Split up the testes. So these are the seminiferous tubules. Look. Good. Okay. Then not more needs repaired. Keep it there, observe. There is no bleeding there. Now I can deliver the specimen with holding the retrieval back, neck. So till now, the position of the patient is head down. No. Now the tilting on the left side, it can be covered. Edik soja karo. Palm side ye karo. Again, I look inside there, sir, hold it. So there is a gallbladder there. This is the cecum. Hold it, Saka to. Yes. So these are the previous oozing, which comes from the open neck of the sac. So there is no specific, these are the magnified view. Few drops of blood is there. Now, and someone go, okay. Okay. Now I change my position. How it delivered? So change the camera 10. Light off. No. So this light always, whenever removed from the telescopes, you must shut down light. Then you can detach from the telescopes the light. So, and now I change the telescopes from the supraumbilical port, change to the right, lateral port. So look inside. So this is the epigastric port. So I can hold it over there. Hold it. So this is the 5 millimeter telescopes. For that reason, the vision is to some extent gloomy. Okay. Now, with the vision inside the camera, I introduce the saw body forces with this, and catch it and remove it out. Wait. So the testis is so slippery, it's very difficult to remove it out through this. The testis capsule is too much slippery. If it is a malignant one, never remove this way. With a benign lesion, for that reason, I remove it out through this manner without enlarging the port. So if you use the thin bag, retractable bag, there is chance of tearing the bag. For that reason, always use either this camera cover, or you can use the remote drain bag. In remote drain bag, there is a sterile cover sheet for covering the drain tubes. So this tube, this cover, you can use it for the travel bag. Sometimes this I use in my hospital.
Assalamu alaikum, sir. This is
Islam.
Parveen.
হ্যাঁ বলো
Sir, dissection এত সুন্দর, মানে আনবিলিভেবল স্যার, খুব সুন্দর ডিসেকশন, এবং হচ্ছে স্যার ম্যাশ প্লেসমেন্টটা তো মানে সেরকম স্যার দেখার মতো স্যার।
Usually not all the time is possible. It is good luck for the surgeon and good luck for the
ভিউয়ার্স অফ কোর্স।
viewers also.
জি স্যার। আর স্যার এখন থেকে প্রায় 6-7 বছর আগে একবার ট্রাই করে কয়েকটা করার পরে 2টা ধরা খেয়ে স্যার একেবারেই স্টপ হয়ে গেছে। এখন আপনার এটা দেখে তো স্যার মনে হচ্ছে আবার বোধহয় চেষ্টা করা যাবে।
I having a 3 sets of instruments. One set is only reserved for the hernias.
স্যার এখন আমরা জানতে চাচ্ছি যে what are the prerequisites for preparation of hernia surgery, sir? How about the instrumental support and as well as the sterilization procedure?
Yes. According to the international formula, all the instruments needs to autoclaving. But autoclaving is not possible all the instrument, because if you use the valve of the 10 millimeter, 5 millimeter port, there is Storz company, so there is some plastic parts remains in the valve. So that part become melted. It is non-functional. So ideally, either plasma sterilizations or you go for autoclaving. These two things mandatory. But our setup is we use all the instruments after doing surgery, dismantling done, then all the parts become free from blood products. Then place it with the Clotex solutions. Then you can keep it your reservation. And whenever you do the surgery, this instrument is submerged in the thigh deck. And before that, some instruments will go with the autoclaving. Not all the instruments. And if you are having a available of plasma sterilizer, or if you are having a available of PTO gas, then you can do surgery with these two. If not available,